Welcome, everyone. Thank you so much for attending the Making Learning Healthcare Systems Conference, More Patient-Centered Conference. We really appreciate you coming out today. I have the pleasure of introducing our welcome speaker, Dr. C. Jean Shea. Dr. Shea is currently a program official at the Agency for Healthcare Research and Quality Department of Health and Human Services. At this capacity, she is the staff lead and the program official for Patient-Centered Outcomes Research Training Portfolio. She is also the lead program official for the newly launched Learning Health Systems Mentored Career Development Program, which has awarded 11 institutional training programs to produce the next generation of learning health system researchers through a K-12 mechanism this fall. Prior to AHRQ, Dr. Shea was the MedStar National Rehabilitation Network for nearly 10 years. While at MedStar, she was a PI, a project director, and involved in several multi-center studies examining best practices for medical rehabilitation among patients with joint replacement, spinal cord injuries and diseases, and stroke. She was also the research faculty creating a research curriculum for MedStar National Rehabilitation Network Sports Medicine Physical Therapy Residency Program, resulting in accreditation by the American Physical Therapy Association. She received her PhD from the Bloomberg School of Public Health at Johns Hopkins University in epidemiology of mental disorders. Dr. Shea also holds an occupational therapy background. She was trained in Taiwan and received her Master's of Arts from Tufts University with the area of interest in psychosocial rehabilitation and group dynamics. Before coming to the U.S., Dr. Shea was a faculty at the Department of Occupational Therapy at a top-ranked university, as well as a joint occupational therapist in an affiliated teaching hospital in Taiwan. So please welcome Dr. Shea for our welcome remarks.
Good morning, everyone. It's my pleasure to be here. And my name is Jean Shea. I'm the AHRQ staff lead and program official for the PCOR 24 grant programs. On behalf of ours, Dr. Francis Chesley Jr. at the Office of Extramural Research, Education, and Priority Populations, it's my absolutely pleasure to be here today to see the fruition of the wonderful work that you have been doing. This AHRQ conference grant supports the Patients program and also brings together all 7 institutions that were charged with building capacity in patient-centered outcome research. And AHRQ greatly appreciates what you have accomplished with your program and also appreciate your sharing of our vision and a commitment to PCOR ever since 2013 when the 7 R24 grants were awarded. Fast forward to 5+ years together, you have established a sustainable PCOR infrastructure within your network partners. You have formed your distinct patient family advisory panel, and many have made a new normal in your healthcare settings. Furthermore, you have connected and disposed fellows, trainees, and faculty, and as well as the community to patient-centered outcome research. This is monumental, and I have no doubt that this conference will bring high impact to the field by disseminating the best practices that you have been doing to a broad audience and stakeholders that are eager and implement the PCOR within their own settings. And with the final goal to improve the quality of care and patient outcomes. So I'm looking forward to the fantastic presentations and posters that you have showcased today. Thank you.
Thanks and welcome. So I'd like to welcome you to University of Maryland, and I'd like to welcome you to Westminster Hall. On behalf of Edgar Allan and myself, welcome. If you didn't get a chance to meet my friend, he's outside and can't come in, but feel free to go say hello to him later on. I also really appreciate the fact that the program officer for this conference grant, R13, Jean Shea, came and brought welcoming remarks for from the agency, and I'm very grateful to the Agency for Healthcare Research and Quality for sponsoring this conference, which will occur this year and next year, thanks to funding from the agency. I also want to mention that I've come to know Dr. Shea over the years. She happens to also be the program officer for the R24 that's here at University of Maryland, and she's the program officer for several of the other ones. So she has really been instrumental in helping us to develop a network. And one thing that I think was very insightful was not only to move forward the idea of how patients can inform a learning health system, but how is it that we can learn from each other? And so one of the great things that Agency for Healthcare Research and Quality did was to set up a network of the 7 of us who receive this funding and to allow us on a monthly basis to learn from each other. So we're very grateful for that opportunity to have shared learnings. Each of us will be sharing our learnings today, but I think it's important to share these learnings across the country and across the world so that every health system can be improved. I also would be remiss if I didn't thank all of the other 6 R24 groups for flying in. Some of you kind of had to deal with thunderstorms last night, and I appreciate the fact that you didn't cancel your flight, that you came in anyways. You'll hear that one of our presenters is not here today. His co-presenter will be doing the entire presentation because unfortunately the airline decided for him that he wasn't getting to Baltimore. But we only had one person who wasn't able to make it in. And then finally, I would be remiss if I didn't give snaps out to those who are in my matching shirts here, who did a tremendous job organizing. So a round of applause to the staff who created this. I did also want to put up the disclaimer that you're going to hear a bunch of presentations today that emerge from these grants that AHRQ gave to 7 groups. And I want you to know that while we're all very grateful and that we've learned a lot and we're sharing what we've learned, that what you hear today is what we've learned and reflects our experiences and what we've learned and may or may not reflect the views of the agency that sponsored the work. So with that, I'd like to bring up the list of other groups that have been participating on this journey for 5 years. As I said, there are 7 of us who received what's called an R24 award. An R24 means to build infrastructure. And we build the infrastructure so that the patient voice can become integral to the way in which we learn how to improve healthcare delivery systems. And so let's have a round of applause for the other 6 groups that are here today. And it has been actually 5.5 years. So we started in 2013 where this network came together. We've been meeting pretty much on a monthly basis. We sometimes take a couple summer months off. And I also want to kind of give a special shout out to Karen Kippen, who's sitting here from Henry Ford, who has arranged the calls on a regular basis, as well as the calls that we had with the agency. So thanks to Karen. And you're about to start hearing the way in which we've learned, but I have a co-PI who helped in the development of this proposal who has been very instrumental in developing this. So please join me in welcoming up Dr. Chris Johnson, who's also going to say hello, and then she's going to transition from that, introducing her team into the first presentation. Chris?
Thank you, Daniel and Edgar. Hope we don't see any ravens flying around here. I also want to do a few thanks to AHRQ for letting all this happen in the first place, to the patients that are here and the patients that are back at our sites who've been, made all the difference and have certainly contributed to a lot of things and made big changes that are going to, I think, last forever. I would like to say thanks for being on on the calls that Daniel mentioned. They've been wonderful. Karen, thanks for arranging them. Kept us together, helped each other take advantage of what we've all been learning. And also, it's been really fun putting this conference together. Diamond, where are you? There you are, right there. It's a lot of details, and look at this, and look at this gorgeous setting. I feel like, well, if I mess up, I know where to say, help me. But anyway, it's been interesting because Daniel's group is a university, and our place is a healthcare system. And you've been very, very focused on community outside the actual hospitals and stuff. And our place has been more focused on the actual healthcare system and patients within it. So it's been really complementary as we've been putting this together, thinking about those two different paradigms. So I think I can, how do I start my slides? Okay, with this right here? Okay. No? This one? Watch. Uh-oh, no. Okay. Okay. So, our center, with the fantastic funding from AHRQ, we established our center from nothing, basically, and we call it PERC, Patient Engaged Research Center. Let me go to my next slide. Whoops. So today what we're going to do is talk a little bit about it, and I'm going to talk about the infrastructure that we set up, as opposed to some of the research projects that you're seeing around the room. I'm going to talk a little bit first, and then our two patient advisors here, two of our patient advisors, Linda Stechenson and Stephen Wasco, are going to talk about some of their experiences, and then I'll wrap up. So right in the middle there is our main quaternary hospital, tertiary hospital, called Henry Ford Hospital. It was established in 1915, it's over 100 years old, with a salaried medical group that, by the way, was a group of docs from Baltimore, from Johns Hopkins. It's expanded over these years into acquiring new hospitals, building new hospitals. The one on the upper left there is the most brand new, and it's quite posh. And then it also includes a number of clinical sites, ambulatory care clinical sites, pharmacies, ophthalmology or optometry centers, and also a very large health plan, an HMO. The main hospital there in the center, not only does it do all the fancy specialist care, but it also serves the community surrounding it. So there's a lot of primary care there too. And that community is inner city Detroit, a lot of folks that don't have a lot of access to medical care. So a lot of them use the emergency room for medical care. And then we have all these clinics and other hospitals are all throughout metropolitan Detroit. So we have a huge diversity of patients. There are a lot, it's really big, and it's been I've been there, I don't even want to say, over 30 years. And it's always been a learning healthcare system, but not in a formal way. There's a lot of things going on, but it hadn't been so organized. There's over 30,000 employees, so it's very complex. Over 10,000 patient encounters a day. It's the hospital, the biggest hospital has over 900 beds, so it's really gigantic. So what we wanted to do was put together a process where it would be systematic, where we would try to address issues, constant improvement, and in this case, really bring in patients. Okay, let's see here. Okay, so when we first started out, and I think we were funded the second round of funding, we put together a strategic plan. We had a retreat and tried to figure out what our goals were going to be. And these were listed right up here. We wanted to make sure we had research staff that were trained in working with patients, engaging them, getting partnerships. We wanted to also create a large network of both community attachments with us, which we have, and then patient advisors, which we didn't have at the time. We wanted to get our core structures together, the processes, and we wanted to get some models together for both engaging patients, helping them and helping people that weren't used to working with patients, put their projects together and have a model. And then finally, we wanted to disseminate this, like I'm doing right now, through presentations, through publications, and through developing new grants. But what I really want to focus on today is number 2, and that was creating the patient advisors group that we have. So we started off with our PERC Center, and Karen, who's already been introduced, was the executive director, and she came from a strategic planning operational background, which was really helpful compared to us researchers. We had 4 cores, the patient engagement core, which I'm going to speak about more today, We also had a data and programming course so that we could pull information out of our administrative data systems, out of our medical records, which we have Epic, and do research with those resources. We had an analytic core. We still have all these cores, led by a biostatistician. And then we have a dissemination core where we try to push out papers and also implement what we've learned even with our own healthcare system, since we're trying to be a learning healthcare system. Okay. So this caught on fire. We are still awestruck by how our patients now, our patient advisors, have been spread all over our healthcare system. Not just research, but all over through operations. In fact, one of our first patient advisors is now on our board of trustees of the entire health system. So, yeah, it's just blown our minds how successful it's been, and I hope the patients feel the same way. I think they do. We just had our third annual patient advisor retreat 2 days ago. It was a day-long retreat with posters like this from all the different patient advisory councils, and it was fantastic. It was a wonderful day with leaders there and physicians and patients and other clinical people. So this shows all the different places that we've had, all the different groups that have been involved with, where we've gotten our patients involved. It's hard to read this from here. Okay, so I mentioned research grants. So many of our grants, most of our grants now, we're trying to engage patients. So for example, I have just awarded a grant to do a birth cohort where we want to recruit mothers, pregnant mothers. So we're getting patients who are the age of pregnant mothers, they're women, and we're trying to have them help us figure out what will work, what will be meaningful, what questions do people want answered. We also work with marketing. Our patients we now have a database of people that are willing to give us information when we are trying to figure out what people want. We have people in patient care experience, in quality, in clinical, and in when we have hospital teams too. Okay. So we have some groups that are based in specific clinical areas. These are the three that have been sort of first established. One is head and neck cancer, one is transplant, and one is brain tumors. We have specialists in all those areas. Our patients have actually made clinical workflows change. They've really had an impact. We have hospital-based councils. We have system-wide councils. As I mentioned, one of our advisors is on the trustees now, but they're in all different areas. And finally, research. I just want to mention here, this is a list of some of our grants that we've been awarded. Most of them are PCOR, but I want to mention All of Us. Do you know about the All of Us program? We're trying to recruit 1 million patients across the country for precision medicine studies. Anybody remember? I hope you know about it. But anyway, we were very excited about getting that. We had to go to NIH to do a reverse site visit, and we took a patient with us. And she, to this day, she sealed it for us. She had the last word, and she talked to the people at NIH, and I think we got it because of her. So patients do make a difference. Oh, I think I'm sneaking into Linda's here. So anyway, I'd now like to introduce Linda Stetchison, right here to my left, and Steve, right next to her. They are both our patient advisors. One is actually a cancer survivor, and the other, Steve, is a caregiver for his wife, Jan, and they're going to tell us a little bit about their experience at Henry Ford.
Good morning. My name is Linda Stetchison, and I'm really thrilled to be here. This is a beautiful venue, and it's nice to be in Baltimore. I'm a cancer survivor. Strange, but I never thought I'd say these words. In fact, when I was diagnosed with cancer on my right vocal cord in 2011, I said to my doctor, "No way, we have heart attacks, we don't get cancer." Unfortunately, though, it was true, I had cancer. It was a routine hearing test. My voice had been hoarse for a while. But I thought, I talk a lot. It was winter, overheated buildings. I was diagnosed with GERD, so I thought, fine, I'll modify my diet. I'll take Prilosec probably for the rest of my life, and that would be it. My doctor, of course, thought it necessary to remove what was impinging on my vocal cord, and of course, at the same time, took a biopsy. A week later, I was told I had squamous carcinoma. I was very fortunate. I was diagnosed at stage 1A. Very shortly after my diagnosis, I began radiation treatment. I had 28 sessions of that, and then I saw my ENT many times during the next 5 years. I was very fortunate, as I said already, that I was diagnosed at a very early stage and that I had wonderful treatment at Henry Ford Hospital. I was very appreciative of that and absolutely thrilled when in 2014 I was asked to become a patient advisor to the Head and Neck Cancer Patient Advisory Council. My participation gives me the opportunity to give back to the institution which to this day provides me with wonderful care. It has been really a pleasure to participate with wonderful Henry Ford staff and very enthusiastic patient advisors. It's so rewarding to work with people who are dedicated, respectful, open-minded, and creative. As a group, I believe we are changing cancer treatment for head and neck patients. We're reminding staff and other patient advisors that cancer becomes part of your life once you're diagnosed, and it goes beyond chemo, radiation, surgery. It becomes part of who you are. In 2016, I joined the Cancer Center Patient Advisory Council. Again, another opportunity to say thank you, another opportunity to give back, another opportunity to be involved with something that's very exciting. A freestanding cancer institute is being built across the street from our main hospital. Our group has been able to assist in ensuring that the center will be patient-centered. We have met with architects and planners since the very beginning. We have been able to share our ideas of what services should be available and what the Cancer Institute should look like. We have given our opinions about how treatment rooms should be set up, what furniture should be used, wall colors, floor coverings. It's just been very exciting to be part of that process. And what's particularly rewarding is the fact that our voices have been listened to. One of the strongest memories I have associated with my 28 radiation therapy treatments is going to the hospital for radiation. I have a part-time job at the Detroit Institute of Arts, which is very close to the hospital, so I elected to receive treatment on my lunch hour. Now that would have been in May and April of 2011. Not May, March. The memory I have, the strongest memory is, of course, rushing from the museum, going to the parking lot, running down the stairs to the very dreary basement of Henry Ford's main campus. What we have been able to do as a group and have been listened to, radiation at the new cancer center will be above ground. It won't be in the basement. For some people, it might not seem like a big deal, but it is. It's much more costly to do it that way. But again, we've been listened to, and it's the patient. It's a patient-centered facility. In April 2018, I was in National Harbor for the combined otolaryngology spring meetings. And I was there with 3 other patient advisors, and 2 of us were filmed for a survivorship video, along with some patients who are being treated locally. As a patient advisor, I have also participated in the development and editing of research proposals and comparative effectiveness research questions. As a group, we have focused on the quality of life outcomes that matter most to ENT patients. Patient advisors have also been active in the development and editing of the project narrative and dissemination plan for the PCOR funded project, engaging patients and other stakeholders to develop a patient-centered research agenda for cancer precision medicine. Recently, I have become an All of Us Research Program Advisor. It is an NIH program for precision medicine, and our task is to advise on engagement and education for both the local and national programs. I think you could tell I'm very pleased to be a patient advisor. I have been given the opportunity to have my voice heard and to improve cancer treatment. Personally, I've also gained much as a patient advisor. I'm working with terrific people and have made some good friends. Our discussions have taught me much about cancer and group decision making. I view our meetings as time well spent and am very, very proud of what we've been able to accomplish. I thank PERC for inviting me to be a patient advisor, and I thank you for being such a wonderful audience and for doing what you do for patients. Thank you.
Good morning. As was noted, my name is Steve Wasco, and I was the caregiver for my wife Janet during her treatment for breast cancer. You probably have heard many definitions of the word caregiver, but ours was simple, and that was we had cancer. And through a courageous and loving 17-year journey through this universe of cancer, after Janet's original stage 4 breast cancer diagnosis, I don't believe I personally missed a single appointment, follow-up, scan, test, referral, consult, sometimes being allowed into settings where caregivers do not go and probably breaking a few rules along the way, but hopefully not hurting anything or breaking anything along the way. And Janet was strong. She pursued every opportunity laid out for her, so needless to say, we both learned about the disease and also learned about all the factors that bring both life and health and hope to the patient. Janet, a principal of an 1,100 student high school until just a couple of weeks earlier, passed away in the ICU at Henry Ford Hospital in August 2017. Her journey during those 17 years, largely in remission, eventually included 3 metastases to her lung, her clavicle, and her brain and spinal fluid. It was through the nearly 5-year cycle of advanced stage that we received care at Henry Ford. So these comments are both a tribute to Janet and her strength and also her tremendous faith, but also to the amazing set of medical professionals who cared for her. These are the leaders in their fields, and we felt we had access to basically every and latest treatment there ever was, every clinical trial and everything else. But more than that, they provided hope. Dr. Ali, her oncologist, Dr. Wolbert in neurosurgery, the nursing staff, the injection team, the nurse navigator really became our friends as much as medical providers, and they gave Janet so much hope that I'm convinced that that hope was what extended her life for years beyond what could have been expected. These were amazing people. In the midst of many rounds of challenging news, somehow Dr. Ali always looked to the future, to the next course, to the next follow-up. There was something about even referring to coming to visit again in 3 or 6 months that provided hope in and of itself. They were available by direct cell phone calls on Sunday afternoon. After her death, 5 of her medical team came and spoke at her funeral. The nurse navigator kept calling and checking on me, navigating my journey for months after Janet's death. So we can talk about the kinds of programs to ensure patient-centered care, but the first is that of patient-centered doctors who provide hope. After her passing, I had contact with Rose Glenn, the Vice President of Patient Experience at Henry Ford Health System, and with whom I had worked with in a professional setting over the years. And I said to Rose that I could purchase a brick on a walkway, and I could probably do other things like that, but that as a communicator and as a strategist, maybe I could offer something else to bring light to the kinds of care that Janet received, to help others. So, just weeks after Janet's passing, while all the feelings were still quite fresh, I was willing to step back into the fray and return to the cancer universe. I had not previously heard of the Patient Engaged Research Center, and Rose suggested that I apply to become a patient advisor, which I did. I became a member, as Linda is a member, of the Patient and Family Advisory Council, PFAC, at the Henry Ford Cancer Center, which had a team working to help build the new cancer center across the street from Henry Ford Hospital. And after being placed on the Cancer Center Council, I also participated in the PCOR Award to engage patients and caregivers, among other stakeholders, to create a research agenda for precision medicine. This very special crew of, we're quite a crew, of current patients, recovering patients, caregivers, and doctors are really quite the cast and crew. We become family, we have fun. We also have direct input and impact into major design areas for the center, not just its architecture, but its atmosphere and its attitude. We know our input translates into change. I'm a very busy person and would not devote my time to something that didn't matter, and I know from my career how difficult it can be to seek and receive constructive input, however large or small, and how making changes to plans and procedures can be. And I must say that I've not seen an institution more focused on this culture of this than Henry Ford. I tell everyone about this everywhere I go. Linda has already covered the detailed work of the Cancer Center team, so I wanted to focus also on the changes that I feel impacted, that I impacted most for Henry Ford's main hospital in Midtown Detroit. And that's through the main hospital, PFAC, which I also joined and eventually became the patient chair. Early on, we developed a charter listing those areas of greatest review, such as the ICU experience, palliative care, even parking systems. And with each successive month, the key system leader for such things presented and sought our advice. Having worked for most of my career in very large institutions, I know too well how bureaucracy, culture, ingrained systems, and even unions can take to move forward and to make change. We had suggested at one point in our early months a change to the after-hours hospital visiting procedures. We felt that they were too restricted, they gave the wrong impression, they created hassles, and just plain didn't focus on families. And we gave some suggestions to a chief nursing officer for changes to be made. And lo and behold, in our very next meeting, just 2 months later, she came and gave a presentation to the group. And at that very next meeting, all the changes that our input had been surrounding had been made. And these were much more than just lengthening the after hours and the visiting hours, but about security and about check-in and about caregiver access and about moving in and around and through the ICU, and frankly, just a lot of complicated stuff. And I felt that I had been listened to, and our lived experiences made visiting their loved ones a bit easier at Henry Ford Main Hospital, especially late at night. I very much feel that my voice as a patient advisor is listened to and acted on by the hospital representatives, and that my experience can and do make a difference to the next patient and their family and caregiver. Thank you.
We had hoped to get 300 patient advisors, and we were thinking, oh my gosh, could we really do this? And we actually have almost 400 now. And what we do is we have set up a program. In fact, Heather Olden, wherever she is, right there, is responsible for this program where, as part of the core, we get recommendations. We have different ways of finding people that might be great patient advisors. Once they are, we have training programs teaching people how to help them learn different techniques for communication, to say things in constructive ways, because many of them have actually experienced things that weren't so great, and that's one reason they want to be a patient advisor. And so, and this is, we're going with this, and it's sustained, and we're just going to help, or hope to keep building that program. As you've heard, we've learned that patients can contribute amazing things and are just matter in every way. You've heard about the contributions to the new cancer center, so architecture and design, and also things like just making it a better milieu for people to be in. We also have, as Linda mentioned, our patients have been involved in helping us choose clinical trials. So we'll propose a trial that we want to do, and they'll say, there's been a few, patients aren't going to want to do that. We have a lot of trials where we don't end up enrolled. We do a lot of effort, IRB, getting people in, all the bureaucracy involved, and then 2 people enroll. And it's a big waste of money and resources. Now we're not doing that so much, thanks to our patient input. We also utilize our patient advisors in our observational trials, our epidemiologic studies, and they help us look at questionnaires, suggest ideas that we might want to look at, what samples we might want to get, or maybe that patients won't want to give, and things like that. So very practical items. And then finally, when we're trying to take our research findings and deploy them, they help us do that and help us know what will work and what won't work. So now I think we are ready for questions.
So we're going to combine the questions together, but if you have questions, write them on a postcard, and anybody with a shirt will come around and pick those up, and then when we finish, we'll go through those questions. From our side, we start all of our presentations with the voice of a patient, so Cynthia will be starting our presentation.
Good morning. It is such a privilege to be here. I think if any of you watch me walk in, it's pretty evident I'm a patient. I have been doing patient advocacy in cancer research and other research for about 20 years. About 6 years ago, I was fortunate enough to meet Daniel at one of the first meetings when they were forming PCOR. And later he asked me if I would come and work together with him in the patients program. It's been an amazing journey. As a patient, I have a number of comorbidities, and I could bore you by listing all of them and be finished, or I'll just briefly tell you that some of them are 2 kinds of cancer, stage 4 kidney failure and stage, wait, I get my stages mixed up, stage 3 heart failure. I have a kind of heart failure for which there is no treatment. So I am committed to research in several ways. One is to bring the patient voice to the research table, to make sure that research addresses the needs of the patients and involves patients in ways that are meaningful to patients, and ask patients to be involved in ways that actually get to answers. I let go of my train of thought. I've been in 7 clinical trials. I am going into my 8th clinical trial now. I also, I believe as a patient that it's my privilege to give back and to engage so that other people in the future don't have to deal with some of the things that I live with. And we can only do that by being in clinical trials. That is how we move care forward. But having said that, when we are in clinical trials, we are not, and I cannot underscore this enough, we are not subjects. We are participants. We are partners. And one of the things that I want to share with you is researchers work very hard, but they live in a kind of siloed world. And as I have worked with researchers, they have told me that having patients engaged, working with them, has changed how they do their research, how they look at their research. So for those of you who are patients in the audience, never, ever underestimate your impact on the research community and on the physicians. You talked about how the physicians have impacted your lives, and I could talk about that too. One of my orthopedic surgeons, I have a whole crew, told me that he's been one of my caregivers for 23 years, and he told me when I saw him last month that when we first met, it would never have been in his wheelhouse to say that I would live this long, much less that I would still be on my own 2 feet. With assistance, but I'm on my own 2 feet. He thought within 3 or 4 years of knowing me, I would be wheelchair bound. He just didn't know how stubborn I am. But I think the best care happens when the caregivers and the patients work together and communicate with each other, learn from each other, and then share what they learned back. And so working with Daniel, and you tell me when I've talked too long, okay? One of the real wonderful things about working with Daniel and with the patients program is they didn't go into the community and say, we've got what you need. They went to the community and said, tell us what you need. Tell us how we can be useful to you, how we can work together to improve your health as a community. And it's one thing to go in and say that, it's another thing to live it. And in the 5.5 years that I've been involved with the patients program, they live it. The community leads the patients program in developing services that are meaningful to and useful to the community. And I think that that is a beacon of light and hope in a world that is terribly fractured right now. So I want you to join me in praising Daniel and the patients program. And that's all I have to say. Thank you so much.
It has been an amazing journey. So we're one of the 7 groups that receive $5 million and hope that we have been a good steward of those funds from the Agency for Healthcare Research and Quality. We co-developed what we were all about with our community, with the patients and the community leaders, as well as the researchers. And the first thing we always do is listen. And sometimes we actually hear what you say and are able to translate it into how we can make health better in West Baltimore, in this state, and in our nation. So we listen to our patients' voices because we know that if we don't ask relevant questions, we'll have 2 people signing up for our studies. We also really do try to align what we research with the priorities of patients. There are a lot of really good questions, but there's no point in trying to answer a question with the community if the community feels that there's a more important thing to study. I am proud of the fact that because of this grant, our program has evolved to become the campus-wide center for all community-engaged research at the University of Maryland across all 6 professional schools. And that to me says that we are transforming the way our university is learning by listening first and then co-developing the way in which we learn through research. And we do take our training mission quite seriously. I'm very proud of the people who have received pilot funding through our grant, who are here to share what they've learned today. I'm also very proud of those researchers who have graduated and gone on to become faculty at other universities, so that what we do here at Maryland can exist across the country. And I'm trying to embarrass Nabil in the back row. A special shout out to Nabil. He's been working with Dr. Court, who was former chief medical officer of one of our federally qualified centers here in Baltimore, to really understand how we can transform a learning health system to a learning health community. And he will be moving this summer to University of South Carolina to be faculty in their School of Public Health to spread what we're doing here to South Carolina. So y'all go and see Nabil down in South Carolina in a few months. I look forward to hearing great things from him. We also felt it was important to learn from those who understand how to make an impact. Some of you may be familiar with WestStat, and they helped us create a logic model. I know you can't see this, and when I teach my students, I tell them never to put up a slide like this. But the point of this is that it is complex to think about what is the logic behind having a transformational impact on human health. And so our colleagues at WestStat, who have been our internal evaluator, have developed this model to guide how we make sure that we don't just talk with patients and develop something, but that we keep ourselves accountable at each step to making sure that the activities that we do will improve health, that everything we do ultimately will have a positive impact on health. And we keep this in the forefront of our minds, that everything we do in research should not just be about bringing in one more grant, should not just be about publishing one more article, but should be about what we said, which is impacting the health of West Baltimore and the nation because we've listened and learned with our patients. And so we do take this very seriously, and we believe that the logic was right, and we hold ourselves accountable to making sure that we have an impact on human health. In addition to our patient advisors, we have some pretty awesome partners who help us with this. If you're from Baltimore, you'll recognize some of these names. Bon Secours Baltimore Health System has recently merged with the Mercy system. And one of the things we're excited about is our learnings locally will now be able to be spread nationally through Dr. Sam Ross and that network at the national level. You may or may not recognize Mount Lebanon Baptist Church, so plug for this afternoon. Come and meet Pastor Lance this afternoon at Patients Day. But you probably remember, even if you're not from Baltimore, that in 2013 we went through civil unrest in our city. And you might have remembered a mall that was being looted, and you might have remembered a car that was burning on Reisterstown Road. Reisterstown Road is the address of that church. But what they didn't show on the news was that not a single window in the church was broken. Because the community understands who's trying to make an impact on holistic health, and the community wants to be healthy. And so one of the joys that I have in my life is working with our partners at Bon Secours and at Mount Lebanon to understand how to listen to the needs of patients so that we don't go through something like civil unrest that's our wake-up call, but that we listen all along so that we can improve the health of individuals and health of communities. And we also have a bunch of other partners, including the Association of Black Cardiologists, who have taught us about working with healthcare providers, patients like me who have taught us about learning how to communicate through social media, because you can't always physically be with someone, but that doesn't mean that they don't want to learn. With our own hospital, and with the Center for Medical Technology Policy that's taught us about how we engage insurers and other payers, because we know that payers have a big impact on the care that patients receive. And our most recent partner is Indiana University School of Nursing, because they understood that they wanted to do what we're doing, and so they were voted in by the other members, and we welcome them and look forward to continuing to spread what we do. We believe that you need to communicate not just through publications, but through videos. So we've published now on our website about 200 videos, thanks to the funding. We've had 21 funded pilot studies, about 10 of which are here today. We've also helped to generate more than 100 new proposals, and we've had funded about 30 of them, including 3 large pragmatic clinical trials. We like AHRQ to hear that we've helped to generate $40 million in new grants and contracts, which we believe as an 800 return on the investment that they invested in us is a pretty good use and stewardship of the funds. And we're grateful that those original funds helped us to do this. So what have we learned? Basically, we've learned that if you don't frame your research question correctly, if it's not understood, how are we going to communicate the answer to that question? If you don't understand the question, you're not going to understand the answer. But we've also learned that that means being culturally appropriate and learning not only how to phrase a question, but how to answer a question in a culturally appropriate manner. So what does that have to do for a learning healthcare system? Well, we have 4 studies, the one that I mentioned that Nabil and Dr. Court have been involved in, and 3 large pragmatic clinical trials funded by the Patient-Centered Outcomes Research Institute of PCOR. The first one is one that Cynthia serves as an advisor for. It's all about trying to figure out which form of radiation is best for women who are diagnosed with stage 3 breast cancer. And we're very grateful to our patients who helped us realize that a title like Proton versus Photon Therapy for Patients with Non-Metastatic Breast Cancer Receiving Comprehensive Nodal Radiation and Radiation Therapy Comprehensive Effectiveness Trial isn't really that informative. And so what they taught us, Cynthia and her peers, was what form of radiation is best for heart health? That's the question in the patient voice. We also are very interested in helping people who have experienced a devastating trauma, be it an automobile accident, a gunshot wound, or some other trauma. And then when they recover from that trauma, the last thing we want is for them to go on and have a blood clot or a pulmonary embolism or a stroke. And so we're trying to learn what is the best way to prevent that in individuals who have experienced significant trauma. And then finally, our third is also a trauma trial, but asks a slightly different question. When that paramedic is bringing you into the hospital, all you can think about is pain. You're probably not saying, well, I hope they get me ready for surgery in a way that I don't end up with a surgical site infection afterwards. And yet we know that the rate of surgical site infections in this country is way above what it should be. And so what we're learning is, what is the best solution that's put on your leg or your arm or wherever you've had that trauma to prevent an infection from happening? Because if you've experienced trauma, you shouldn't go on to experience some other negative consequence. So those are the studies that we're helping to inform, and we're very grateful to all of our patients who have helped us to frame the question in the study so that it's patient-centered. And with that, I'll turn it over to Hillary, who's going to come up and ask a couple questions with Diamond.
So the first question for Henry Ford, how are patient advisors organized? Do you meet with them on a regular basis? How do you disseminate the clinical questions to the advisors?
I'm involved with 3 groups. One of the groups meets monthly. The other 2 meet bi-monthly. And information is shared and coordinated by Karen Kippen and Heather Olden. But the rest of the question.
Yeah, I think, well, can you see the questions again? I was just writing them down and
so much there.
So how are patient advisors organized? Do they meet on a regular basis? And how do you disseminate the clinical questions to the advisors?
I'm going to pass this to you too, but it varies depending on the different group, and we have a lot of different groups. For example, when we have studies that we're proposing, we run them by the people in the meeting and ask them, depending on if we're reviewing questionnaires or reviewing ideas, we just get feedback. And I guess Heather might want to add something after Steve.
I'm not sure if this was made clear earlier, but when you kind of raise your hand and say we want to be involved, you're not quite sure necessarily what group you're going to be associated with. It may be the clinic or the institute that you had treatment or your patient had treatment in, but it may be some other as well. And there are new groups forming all the time. One of the novel approaches is that there'll be a regular email that says there are new PFACs forming in this, this, and this. If you'd like to join another one, please raise your hand and go through the training and that sort of thing. And that's just really a great way to share that information as well.
one of the things that I have learned is how the group process works. And it's very clear that everyone has a voice and everyone gets a turn to share. Sometimes that's not the easiest. Sometimes you want to say, enough already. But we make sure that people, their opinions are respected and listened to, and that no one walks away thinking, well, why didn't I get my turn? And it's again, one of the things that you learn as a patient advisor is the group process and how it best works and how it sometimes falls apart. But that's why we have leaders like Heather.
Thank you. So our patient advisors can be organized in a couple different ways. It can be a PFAC, a Patient and Family Advisory Council, which is 15 to 20 advisors, and then you have a council champion who's the liaison to the health system. And then we also have individual placements. So when Dr. Johnson was speaking and there was a circle of the types of placements that we have, at the very bottom was an ethics committee. So that's an example of an individual placement where a committee that already exists at Henry Ford has a patient or two at the table to represent the patient voice. And then as it relates to how we communicate or the clinical questions that may come up, sometimes we have people reach out to us who want to attend a PFAC meeting. Of course, it has to be within the scope of that PFAC, but they'll run a research idea by them, or they'll even bring a letter of intent to the group to review. But we also have people who prefer the virtual route. So we have a virtual component where we can send things out to our patient advisors in this monthly e-blast that Steve was referencing. And it's just a way to keep everyone in the loop. And so one of the unique things about our program is there's a place for everyone. So if you can't come in and be in-person participant, then you can do that online. So we've tried to find a place for everybody.
So we certainly, we're very fortunate to have all of our speakers here today. So please, during breaks, if you have additional questions, to come up and ask. I'm going to move on to another question that is for Henry Ford, but I think Cynthia might be able to answer this one too, which is, do you have any publications that your patient advisors are co-authors and or lead authors on? And then how do you advocate for those things to happen on a more frequent basis? So I want Cynthia to go first, and then Henry Ford.
The question was about co-authoring papers?
Mm-hmm.
Okay. I've co-authored a bunch. I think it's a really important role for the patient to be engaged in writing and sharing their thoughts about the research or about what is happening. I sometimes co-author. I've co-authored with Nabil, which is an amazing experience. Sometimes I just write myself. I have a lot of things wrong with me, and I have a lot of chronic pain. I hate the chronic pain scale. I think it is a tool, it's a useful tool. It was developed in hospice to help people who can't readily verbalize what's going on, to give them a picture to point at or a number. But what's happened is the Joint Commission has decided every doctor must ask you the pain scale every time they see you. And I've gotten, so I say, which part of my body are we want to talk about? But so I wrote an article about that, and I got it published in a medical journal from the patient's perspective, what it's like to deal with the pain scale, and how sometimes it keeps you from really knowing us. So I think as a patient, if you have thoughts about medicine, about care, about the system, then you have a right and maybe even an obligation to share those in a meaningful way with the treating community. So I very strongly believe in our voice. The other thing is, if you think you can't write, then get a tape recorder and talk out your thoughts, and then grab someone like Daniel or Nabil and say, I want you to help me get this out. It matters. And I got, what journal is it? One of the circulation journals, I got them to start adding a page in the journal just for the patient perspective. And I think your voice is really important. Don't underestimate it. and call upon people like Nabil and Daniel to help you get it out there if you happen to not see yourself as a highly verbal person. You are, you talk all the time. It's just a matter of putting that talk down on paper.
Yeah, real quick. I'd like to see your paper because a lot of our patients don't like that pain scale either. So please give it to me. We were just talking about it. We're working on a lot of papers right now. We've had mostly so far posters. At our symposium a couple days ago, we had 20-some posters. Patients were on, some of them were the only authors on those posters, and others included both scientists and patient advisors. And we've got a few papers out, but truthfully we're really working on that right now because it's our last year no-cost extension and we're working on it. But we do include our patients on our dissemination products.
Can I say one more thing? I used to be shy. My new philosophy of life is ask anyone any question because they might say no, but they can't say yes if you don't ask them. And so that's what I think for patients writing. Ask if you can write. If they say no, make them tell you why. And if they say yes, tell them they need to help you.
We're going to begin again with our first session, partnership approaches to advanced community engaged research. I'm going to bring up Dr. Wehe from Indiana University.
Thank you, Diamond. Okay, I'm going to try and negotiate my laptop, which has the notes, and this laptop, which has the slides. So if I don't do that well. So I'm Sarah Wehe. I'm a pediatrician and a health services researcher at Indiana University School of Medicine and the director of community health partnerships as part of our Indiana Clinical and Translational Sciences Institute. And for our R24 project, I was the director of the Patient Engagement Corps. And Aaron Carroll, who is the PI of that R24 application from IU, had asked me to come on his behalf to sort of talk about how we have made our Patient Engagement Corps sort of more integrated into our institution and sustained. So I'm going to talk just super briefly about what we did in order to allow some of our patient partners to come up and tell you the really important stuff. I guess that's what this is for. Okay. So for our R24 project, we had 4 studies that were initially funded as part of that that used our one patient engagement core. And as part of that, for each study, we looked at recruitment and retention, adherence and measurement, as well as dissemination through our patient engagement process. We involved the patient as early as possible, sometimes as early as should we even write a grant for this, like what is the most relevant question, where should we start, but for the R24 projects, these were already sort of developed proposals, and so what we did was engage a group of patients that met study inclusion criteria to reevaluate the study design, reevaluate the recruitment strategy, try and troubleshoot issues throughout the projects that lasted 2 to 3 years each, and then help with dissemination of the findings. And even at the end, what we tried to do was switch the roles to put the patients in a principal investigator role with us as co-investigators, and sort of submitted mini grants back to AHRQ for funding of projects that they developed. Our approach, we really try and go below the surface to include tacit and latent knowledge, and we do this through very engaged techniques that are sometimes seem a little strange, like collage and role-playing and very hands-on type of things. This is ways that we can get at things that from a patient or other stakeholder's standpoint may seem mundane, but are truly really important to help shape the research process. And finally, we believe that perfection is sometimes the enemy of the good, especially in an academic setting where sometimes it can take 10 or 15 years to get from a research question to something that's disseminated back to the community. And so we try and implement a rapid prototyping model to get useful tools out into the world as early as possible, and then with continued collaboration with patients and stakeholders, refine that. So what we have used is human-centered design. This has been applied in a lot of other fields, but was relatively new with this R24 grant to be applied to medical research. And we found that it has been very successful to act as a translator, if you will, between researchers and patients. And it is sort of our primary approach of how we engage and sustain that engagement. What's also been nice about that process is that by having our team of design research folks, what we offer back to the principal investigators is not just a report of findings, but also these prototypes or tools that they can immediately put into the field. So what does this mean for the learning health system? Oopsie. Is that I'm going to actually go very quickly here because I just got the 2-minute warning and I'm already babbling too much. I'm sorry, but are these tools to get patients engaged, but then are also in implementing them back into the healthcare system through dissemination on sort of the back end. So how do we measure success? From the very beginning, what we found was that a lot of investigators were coming sort of out of the woodwork to ask for these services that were intended to be used for the R24 projects only. So we went to the Clinical and Translational Sciences Institute to help support our services to be expanded more broadly. And from that, actually, we started in 2012 and focused just in the first 2 years on our R24 projects. It rapidly increased in terms of the number of projects that we've gotten involved with and grant applications that we submitted, and many of those were ultimately funded, and that's the bottom line from a financial standpoint of how we were able to expand and sustain these services more broadly. And the projects sort of reflect that funding that was initially with a core bit of funding through the CTSI and a little bit that as the other projects were funded. And we very quickly maxed out the capacity of our very small team, and so grew, and the projects got bigger, which meant that, as you can see with the blue things, our total portfolio of projects, we weren't finishing off projects as quickly, so it just grew and grew and grew, and so now we have a portfolio of 25 to 30 projects, and I promised no more projects this year, but there were 4 more that were just too interesting to pass up, so this is where my team are sort of gritting their teeth, but it is a labor of love. So I'd like to introduce Billy Bennett, who was one of the PIs of one of the R24 projects, and so was a stakeholder in one respect for us as a clinician, a physician scientist, but is also a patient as well, and then he'll introduce his additional patient partner. Thanks.
I've been kind of the interesting position of being on both the investigator clinician side of this and on the, I guess, parent of a patient side of things. So I'm a pediatric gastroenterologist at IU, and our R24 project looked at screening for anxiety and depression in the gastroenterology office. And a big part of that was figuring out, well, how do you do that to meet patient needs and desires related to a very emotionally charged diagnosis. And we've just finished that trial, and that's hopefully going to transition to R01 funding. We had another project that was funded with an R21 in collaboration with urology, looking at procedure choice. And we've done several other projects related to things like liver transplant within GI. But the most recent thing that has really obviously very dear to my heart, so my daughter, Cecilia, who's 3, She has this really rare genetic condition called Phelan-McDermid syndrome. So it's a chromosomal deletion that causes severe autism, seizures, GI problems, and then they have about 80% of children are nonverbal or have very limited communication, and a large percentage don't walk. So these are very handicapped children. And I was fortunate to recently receive a PCOR award for a conference grant for the Phelan-McDermid Syndrome Foundation. So it's really helped me kind of shift into understanding, well, what do I need to be doing as an investigator, and then what do I need as a parent of a child that benefits from enhanced patient engagement. And so I wanted to actually invite one of our other guest today, Megan O'Boyle, who is part of the Phelan-McDermid Syndrome Foundation, also has a daughter with the same disorder, to just give us a brief overview of where that intersection is for patient engagement in these rare disease communities.
Billy was very polite in saying Phelan-McDermid syndrome. When my daughter was diagnosed in 2001, it was called 22q13 Deletion Syndrome Foundation, which didn't fit on a check, so we were like, well, we have to rename it. And clearly the parents who renamed it Phelan-McDermid syndrome, Phelan's with a P, were not in marketing because the letters spell PMS. So I'm going to refer to this, as I always do with my child with PMS, and we also have very cool t-shirts that say PMS, it's not what you think. So I have very little time. I had no interest in research, I just wanted to get my child through the medical system and the education system and through life. I was recruited because I live near NIH and our foundation needed a patient registry. And so I was thrown in the deep end of research and I've been treading at water ever since. I've been fortunate to work with PCOR on a 5-year PCORnet award, to go to tons of meetings about patient engagement. And frankly, I was baffled because I didn't understand why we had to teach anybody that the patient was at the center. Like, who's been at the center all along? I don't understand. So I've heard a lot from groups like this. And there's a few things that I want to impart or that I want you to think about today. One is from the rare disease situation, most of our doctors have one child with PMS and they don't know what to do. So as parents, we either need to get educated on everything that we can find and impart that to the care team, or we're leaving it up to the care team to Google. So our patient registry has data that we've collected, genetic and clinical and developmental, and we make that data available in real time, aggregated charts, so our families can go in and say to their doctor or their IEP team at school, my child is nonverbal, 80% of these kids don't feel pain, they don't sweat, they're susceptible for seizures, my child needs a one-on-one at recess. Or, I know you don't think my kid has reflux, but 80% of these kids have, silent reflux, order the test, darn it. So it's really important, especially in the rare disease community, that caregivers and patients have to learn about the disease. It's just necessary, it's not an option. And they have to be listened to. And if they're not listened to, they have to move on to another care team. And that example I just gave, data is street cred. It's much, you walk into a doctor's office, he has 2 minutes, and giving him a 12-page PubMed article about a disease isn't the best way to do it. So the snapshots of data has been really an effective thing for us. In terms of participating in studies, clinical trials, surveys, I think it's super generous that people write into their awards that, we're going to give all participants an Amazon gift card. That's great, but I really don't want the Amazon gift card. I want the data back. I want a lay summary, whether it worked or it didn't work. I'm okay if you failed, but I'm sick of filling things out and not finding out if it was published, and if it was published, can I afford to buy the publication, and if I can afford to buy it, can I read it? So dissemination in lay terms is really important. I was taught at a recent meeting by somebody at Vanderbilt. Her name is, what is her name? Consuelo Wilkins. And, there was a whole hour set, like, what's the definition of engagement? And I was like, and finally she said, engagement is when change is made, where there's a bi-directional, exchange of information and somebody changes the way they're doing things. It's not just listening and then doing things the way you've always done it. And I think that's a really smart, easy measurement of engagement. Another thing I want people to think about, and maybe this is just me, but I don't mean patient reps. Why is the patient who's being part of the research, why aren't we in the IRB? You know, I hear about IRBs protecting me from things that I don't want to be protected from. I don't need a crash helmet and 7 seatbelts. I just need a seatbelt. And maybe I'm willing to take risk that the IRB doesn't think that I should. So I think there needs to be a change in that space. And I don't speak on behalf of anybody else here, so, you know, I'm not trying to get anybody in trouble. I think when you're building a program like all the programs that you've built, I think everybody should keep in mind scaling. Don't just build for your community or your institution. Build for, you know, as Daniel said, let's share the love, spread the love. If this is something, then get it out there so that other groups can benefit from it and use it. And my parting thought would be, we are literally preaching to the choir. Everybody here you're all on board, you all drank the Kool-Aid. Who's not on board, and how do we reach them? And why aren't they on board? Why do they think patients get in the way of research? And what can we do? How can we train patients better to be more effective advocates? And how can we get people who aren't listening to listen? Thanks for your time.
Thank you. I'm Natalie Ritchie. I'm a health psychologist with Denver Health, and I'm delighted to be here. I was one of the mentees under Denver Health's AHRQ grant, and now recently became an independent investigator. Yay! Thank you. And to all the other million people who helped me get there over the last 15 years. So that's how long it took from the start of grad school. But I'm pleased to be talking today about establishing a community advisory panel at Denver Health to promote patient-centered research. And we hope that these lessons can be shared by other safety net healthcare systems as well as others in general. And I'll be presenting today with my colleague Sylvia. I just wanted to start by giving an overview of the Denver Health System. So we're a safety net for the city and county of Denver. We serve about 1 in 4 Denver residents, and we have a variety of missions. Of course, clinical care is being our center. We also focus on education and research. I'll just leave this slide up here for a moment so if anything catches your eye, but we have a health plan, we have a hospital, we have specialty care centers, we have community clinics, etc. And now Sylvia will talk specifically about how we formed our community advisory panel.
Thank you. I'm Sylvia Gutierrez. I'm the facilitator in our community advice panel. And one of my roles is doing the recruitment of all the members of the community advice panel. And before that, with the R24 grants, I was the community member. So after that, I tried to organizing the community advice panel. So because I will talk about the end, so I bring up pictures. I always say, my mom say, don't talk about people that they are not in the room, right? So here they are. We have 8 people in the community advice panel. 2 missing in the picture because they left early that day. The community panel is amazing, and I wanted to start talking about the value. You see the values over there: trust, inclusiveness, respect, listening, and thoughtfulness, transparent, meaningful, and for sure action. So as we know the definition of those words, you can see the power of this community advice panel. I'm sorry, my English is a second language, so I thought I can start doing this presentation in Spanish, but somebody said, no, please don't do that. So, so here is one of the comments that one of the researchers involved with the CAP said. Your job is to make us a little uncomfortable. So that means the community advice panel did a very good job with them, right? Because that was their job. Their job is asking questions, giving advice, and sometimes they don't like that, right? Sometimes they go over there thinking that everything is perfect, but that is why we have that community advice panel, to tell us that's right, that's wrong, or it's not even wrong, it's like adding stuff in the programs, adding stuff in the research. So I think that comment was very good taken. I've been working in Denver Health community. Actually, in Denver Health, I've been around 8 years. But in Denver community, I've been around 20 years. And I've been 18 years in research. So my first community advice panel I put together was for a program named Luchar. That was a cardiovascular disease program. So, so we were talking about the way that we can put community advice panel together and engage the community. How we do that? So, here's. So we identify panel members. The way I do is like I spend a lot of time with the community, my face there. I participate for health fairs, volunteers here, there, and try to talk to people. Sometimes we think about putting some community advice panel together is that somebody giving the names and that's it. That's not enough. Sometimes researchers need to be in the community, to be involved with them, giving something. You know, volunteer is one of the best ways to do that because you start know people around. So the other way we do is referrals. So some of the community advice panel giving us names. So I interview them. I always say interview is a formal word that we say, but really I go to the community, I doing something like we call cafecito. That means we go to the coffee shop in their community. I go there, maybe a block for their house, when they have a little cafecito there, sit down there and explain what that means, be in the community panel. What that means, research. Because sometimes they don't have the knowledge, but they want to know more. So that makes me the time to educate them a little bit, and at the same time, they know what they signing for. In that time, they deciding if they want to be part of or they want to pass. And sometimes they do that. They say, you know what, it's a lot of commitment. I don't think that I am right now. But that is the time that they can decide it. So one of the beauty of our community advice panel is the diversity. We have underinsurance, we have homeless, we have Latinos, we have African American, we have, you know, you can see all the list. I think that is one of the more representation that we've been having. I need 2 more people, so I thought about Cindy and Linda to take it to Colorado, but I don't think they want to go all the way over there, but we are 8, we have 2 more space. I'm working on that right now. So this is one of the more, for me, power when what is the representation of our community when we think about putting some community a panel together. You have to think about those components. Here is some tools of success. I don't want to go to each, but one of the things I want to tell you is that be real. When you are putting something together for that, be real, and you are writing grants, please put some money too over there so you can pay a little bit, because some people in the community, they are open to doing free, but it would be nice to give in something at least for the transportation and for their time, because their time is a value too. The other thing is, like the phrase of the research, the phrase of the research said, for me, there was a very value there because they're there for the research. They are opening the heart. So it's important to, given the value of what they said, acting on that. Even if the grants cannot do it, be honest with them and tell them why not. And the other things I always stand up for me is giving back to the community. Dissemination is very important. I think a couple people mentioned already. Go back to the community and say, what do you find? Giving those details. And that is one of our CAP job to disseminate it. So be part of that. So now, Nali presenting on the CAP. So that was amazing. She can give in the experience.
My work focuses on the diabetes prevention program, and we found that it's a great program, but it needs a little tweaking, specifically around goals. So right now the program says that everyone who goes through it every week has to do 2.5 hours of physical activity. The program doesn't give exceptions if you have one leg or if you don't like physical activity, and we found that that was problematic in causing people to drop out. So we piloted a new tool to allow patients to choose a variety of different options that they want to work on each week to help prevent diabetes, and they can change what they want each week. They can learn from their experiments, as you might call it. I did have the chance to present to our patient advisory panel midstream to get their feedback, and I would say, yes, I knew they were going to make me uncomfortable, so I went in being like, okay, this is going to be like getting reviewer feedback. And it is intimidating. You know, I thought, what will they think of my work, and can I address their feedback appropriately and respectfully, knowing the constraints of research funding? I did leave with some great takeaways, which is feeling that my efforts were valued, that this was a priority topic, that they felt like even if they didn't have personal experience with diabetes or needing to prevent it, that I should be doing this work, and that just felt so important to me. They had great actionable, concrete suggestions, which was to not even talk about it in terms of goal setting, that felt pejorative itself to hear that, and just keep it more loose. Like, you know, what do you want to work on this week? What do you want to change about your routine? And that we should also add a goal to focus on fewer alcoholic beverages, which just wasn't on our list of suggested goals. So I appreciate that. They also helped me think of bigger picture needs, like reminding me of the importance of trauma history and how so many of the people who are likely to be coming into our programs will have a trauma history, and that we need to think in the future of how we can better address that, as well as being able to hire more broadly representative lifestyle coaches in the future to make sure that everyone who comes through the program feels like they have a coach that represents their values and their priorities. Oh, sorry. Do you think that our CAP has provided additional benefits? They serve on our provider selection committee. They support junior researcher education. They've supported having a culturally congruent healthcare process and product, which I think has been exemplified by the other speakers here today. They also strategically help with research. It's great to be able to show that you have a letter of support from a community advisory panel, that your ideas have been embedded by them, and we hope that that ultimately leads to better products and partnerships for the future. So I have a closing line here that we believe in the power of community and the power of strong relationships. Thank you.
So Ethan Halm is the PI who works with our PCOR Center at UT Southwestern and was bumped from his flight yesterday. So he asked me to present his slides that he had prepared to talk with you about a couple of pragmatic cancer screening studies that we've done at UT Southwestern. I'm Brian Elwood, and my role, among other things, with the PCOR Center and at UT Southwestern is coordinating our community advisory panel. So I'll chime in and try to ad-lib as I can with these slides to tell you more about this. But just to start, to give you a little context of where these studies are happening. So Dallas is a big city. And it's served by the Parkland Health and Hospital System as our sole safety net provider. We see something like well over a million patients a year come through that system. There's a central hospital, and then there are 12 satellite clinics throughout the city. And the slide will give you a snapshot of our demographics that are served by the hospital. So one of the things that investigators at UT Southwestern were interested in were the high rates of colon and liver cancer, and especially among uninsured populations. And in fact, a lot of the population health studies that happen at UT Southwestern are done with patients of the Parkland Health and Hospital system. So it was important to us when we put our community advisory panel together that we have good representation of patients who utilize that system. In this case, the studies were, the colon cancer study was focusing specifically on people ages 50 through 75, although we stopped recruitment up to age 65 for that study, simply because once people hit Medicare eligibility, they might be seeking colonoscopies and that care outside of the Parkland system, and not solely relying upon Parkland. And then eligibility for the liver cancer screening were patients with a history of cirrhosis. You know, historically, most of this cancer screening happens just in the context of routine care as patients are coming in for visits with their doctors. And a lot of things have to get covered in those visits. So depending upon what's going on for the patient, whether or not the discussion about having a colonoscopy or doing ultrasound screening for liver cancer makes it on the priority list for those few and compressed visits can vary considerably. So doctors have a lot of things to cover, and we were trying to find ways to make this kind of cancer screening more routine so that there might be more uptake, more of it might be done. The way the studies unfolded is that we recruited patients from the EMR, identified patients from the EMR. The colon cancer patients were going to be sent a FIT kit to be done at home, a fecal test kit to be done at home, and then the liver cancer patients were invited to come into the hospital for an ultrasound screening. The usual care group would just be whatever happens when they're routine medical visits. This slide will outline what we did for each of the studies. Trying to get it all compressed in 7 minutes. It's confusing for me. I can only imagine for you. So for both studies, there was a patient and stakeholder engagement. For the liver cancer screening study, the investigator looked to patients in the clinic, patients served by these clinics, by other clinicians who work in the ultrasound clinics, other providers in the hospitals, and also national advocacy organizations. So we sought input from that group. The liver cancer screening was also a project that was funded by our R24 grant, whereas the colon cancer screening was funded through as part of a PROSPER study, so funded through another mechanism. Both of the studies involved patients getting a letter that says your doctor recommends that you have this screening, basic information about what the screening opportunity is. Importantly, the letters went through a language validation process where we had patients interpret what we were trying to say. In other words, we would give them the letter, give them the language and say, what does this mean to you? Do you understand it? And we would get feedback from them and revise the letters so that we were sending out something that was meaningful. And they were translated in English and Spanish. And again, that language validation is done in Spanish as well. The liver cancer screening involved a phone number that people could call to schedule their test. That was important because if the patients were responding to the letter, the appointments were expedited. Otherwise, the backlog for getting this kind of screening done in our Parkland system can be up to a year. So there was an advantage if people were calling in response to the letter. With the FIT kits, they were sent the kits, there were reminder phone calls, and then for each of the studies, for the colon cancer and the liver cancer screening, if there were abnormalities found, either with the FIT kit with the colon study or abnormalities on the ultrasound test done with the liver cancer screening, there would be a nurse practitioner who would follow up with the patients to make sure that the appropriate next steps were followed. So what did we find out? Well, the good news is that we increased screening from 30 to 59% in the colon cancer screening study, and for liver cancer increased from 47 to 69%. The bad news is that many people still didn't get screened. So despite this, this outreach initiative, there were still folks who were not getting the testing done. And a big obstacle that remains is helping people understand that in all cases, this isn't a once and done thing. So getting people to repeat the testing as needed. What does it mean for health systems? Well, a big takeaway for us, and it was where we started really, was the belief that we need to meet people where they are. So trying to get this message to people, to them at home. So we used a targeted mailing approach, this is where Alice will be able to give you a little bit of feedback. Alice is one of our community advisory panel members. The CAP met with the research team about the colon cancer mail-out initiative, so I got some very explicit input from them. But you know, as successful as these studies were, the takeaway is that we still need to find better ways to reach more people and to make sure people follow up, especially after abnormal testing. So I was timing myself with 7 minutes there. Very briefly, I want to give Alice a chance to speak with you a little bit about her experience. She's been on our community advisory panel from the beginning, which is 4 years now for us, and has been at, I think, all but maybe one of the 30+ meetings that our panel has had. So, Alice.
Well, good afternoon, probably in Dallas, but here I'm not so sure. Our advisory panel reviewed the materials that the colon cancer screening study was sending to the patients and had a lot to say about this. If you want to open a letter you send them in the mail from Parkland, make sure it doesn't look like a bill. Use a colored envelope, not white. Say something on the outside to get their attention, like the important information about your health inside. Cluster letters so they're sent to people in the same neighborhood at the same time, builds interest and concern. People can talk to each other about it. Run videos talking about these health issues in the clinic waiting rooms so that when people get information about these kinds of studies in the mail, they might remember having heard about colon cancer or liver cancer and the importance of getting screened. I just want to say a few words. I became a patient advocate because I believe in change. I believe in change in health care. And with many health care issues, this was my opportunity to make that happen. First of all, if I can ask you guys from now on to explain what research is when we are out trying to recruit people, because the concept is they want to try experimental treatment, and sometimes that is true. But research is also just giving back information and feedback, which need to be heard. I believe as long as we continue to listen to the message and not focus on the messenger, the change will continue, not just in this generation, but in the future generations to come. My mother would say, a baby can teach you anything. Together we stand, and divided we fall. Thank you.
We're going to take the time to answer questions. If you have some index cards, we'll have some people grabbing them on the way. No worries. And those questions can be directed towards any of the people on the panel. So I'll ask a question to Natalie from Denver Health. As a junior researcher, what did the process look like for you wanting to reach out to CAP and developing your own research?
Thank you. So my experience was that it was so easy because the CAP was already established at Denver Health, so I didn't have to do all of the legwork that can be so hard when you're just focusing on a small project. So it existed. I was able to easily schedule a time to give them, the infrastructure was there to get the feedback readily. So I just appreciate that that was already in place.
This is for Megan. I was curious about your IRB comment, if you could follow up on that. Now, I think our IRB actually has patient representatives on it.
I think all or most have patient representatives on it, just like FDA has patient representatives and biotech does and pharma does. But what I'm talking about is if the study is about a specific disease, then the patient representative should be a member of that disease community. Not somebody, I respect a cancer patient or a diabetes patient being willing to volunteer their time to be an IRB, but they don't understand the risk that I'm willing to put my child or myself through to get a better quality of life. And so they can't really speak to me. And that's especially true in rare disease where, you can Google it and there's not going to be anything that they're going to really be able to learn. So I think that there needs to be, more inclusion. I personally think that there is a environment of fear that I've noticed. In the PCOR project, I suggested something, and the researcher said, "Oh, the IRB will never let us do that." I said, "I just said it 5 seconds ago. You haven't talked to the IRB, but they won't let us do it." And then the IRB is afraid of OHRP, the regulators. And when we've talked to them, the regulators will say, "Well, they're just misinterpreting it. We didn't mean it that way." And so there's this whole environment of fear, and nobody wants to lose their funding or lab or get in trouble. But if we really are truly patient-centric, ask the patient what they're willing to do. I mean, if this is a terminal disease, they're probably willing to do a lot more than the IRB might think that they are. And again, this is a personal opinion. I've never been in an IRB meeting.
So for the patient panelists, what should a researcher remember when outreaching to the community to do a research project? To patient panelists or community patient panelists.
I think, as I said before, it's important to educate people on the word research. That is such a fearful word. Because I had a cardiologist to call me the other day and ask me to participate in this research. And he didn't go into detail about all of it, and I'm asking him questions and he's evading the answers to give me. So I've told him, you need to explain what the research is. How deep is it? Am I gonna have to take shots? Am I just gonna take medicine? Are we just gonna talk? What is it? And then I learned what it was, and then I did not want to be a part of it.
I would say, when possible, prior to identifying the study, go to the community and ask what their goals are. And I'm not accusing all researchers of doing research just to get published, but a lot of times what the patient community needs is not what the researchers are thinking about. And I also would start with a very simple question. Talk to me about your quality of life. What do you wish you could do? Not everybody wants to live longer. They want to be able to use their hands longer. So I think it's important for the research community to stop and listen to what daily life is like, and then form their studies.
I mean, I can comment kind of on both sides of that issue, both designing research studies and having my daughter involved in them, is that I don't feel like there's hardly any involvement with patients when forming the research question. And so, and typically the studies that people do are, like, the outcomes don't fit with what we want as parents or patients. the process. For instance, in our community, there's a big autism center in New York City that's running a trial, and that's nice if you live in the Northeast. But it's really finding out, well, what's going to get people involved. Most families in our community are willing to fly. I think before you ask the question, if you engage families on both the process and the hypothesis, I think you're much more likely to have impactful research that will be successful.
Sylvia, did you have an answer?
Well, I would say that when you are in the community to try to do the recruitment, I would say be clear what you are saying. I can talk about the Latino community in Denver. They still are afraid when they hear the word research, estudios, or investigación. So that's a big word for them. We still have a lot of work to do in the community they can understand exactly the word research, and because they're being afraid because so many people, they don't explain what the research means. Can be a research on the very simple research, but they can be a very complaint research. So the community is still not there yet. So it's a lot of work that we have to do to make the bridge and to be clear in the community about research.
Can I ask a question? Sure can. Is there any way that the word research could be changed to something else? Have that thought ever happened?
So when I talk to my community or even my family members about research, I try and not use that word. So I try and say, do you want to be a part of, so if it's a qualitative study, a discussion, or even a project, but when you say research, it does in certain communities, it makes them clam up. And so a lot of the things that Henry Ford has been trying to do is how do we change the narrative around research so that people don't clam up, but it's not something that can be solved in a day. It's something that has to be sort of a culture shift as a whole.
Any other questions?
If there's a question, I'd rather than, did you have a question?
So you had mentioned about the cafecito meetings. So do most of the engagement or meetings, do they occur at your facility, or do you actually bring the discussion into the community in a facility or in their homes or whatnot?
Yeah, that's a great question. That is in the initial meeting. That's the kind of introduction about what CAP mean, the Community Advisory Board, and what research mean. If sometime they coming, maybe they pass already 3 or 4 sessions. So like I'm looking for 2 more members. So I'm going to the cafecito and explain what we've been doing. So, and then we meet in our facility in the hospital. So we meet in there. They are contribute there. We're asking them where they want to meet, and they always say, "Oh, here is perfect." So we meet in there. But the first meeting, I go to the community. I sit down with them for almost 2 hours, sometimes 3 hours, because they give me a story, and I love that. So yeah. Thank you.
Perfect. Any other questions?
I just have a comment. We started our patient registry, parent-reported registry, to really help the researchers. We recruited our families who trusted us. We consented them with an 8-sentence consent, not an 8-page consent. We collected the data and we disseminated it. And we were very proud of ourselves. We weren't thinking about ourselves, the families. And the families are actually the ones that used the data first. They took those charts to their doctors and their schools. And although we had a 60% involvement in the registry from around the world, it really didn't click. We kept saying, do this to help the researchers. We finally said what the value proposition was for the families. Help us, help the researchers, help your child. And we explained to them why their participation in this was going to empower them in the doctor's office or in the school setting, and why knowing more about this would help them find, I diagnosed my child with 2 of her medical conditions before the doctor saw it, because I knew to look for it and he didn't. So I think you really have to think back, what is this going to do? What are you doing for them besides taking their blood and asking them to answer, a 2-hour survey? Are you going to return that data so that they can do something with it? Are you going to use that data to apply for more funding that may help them down the road? But I think, to your point, you really need to explain to them what the value proposition is. And yes, the consent question says there's no benefit and there is risk, but try and make sure there is a benefit somewhere, and communicate that.
This is a slightly different topic, but we haven't really had much discussion or haven't heard anything said very much about how we get feedback from our patient advisors, and in our case, our community advisory panel, at least collecting it in any sort of a systematic way. And it strikes me that that's a really important thing to do. It's something that we do in a rather simple way, and I'm not at all satisfied that we're doing it in the best way, or that we shouldn't be doing, taking a different approach. But we generally meet about once a month with our group, usually in response to a question that a researcher wants to bring to our community advisory panel. And I've got a kind of a standard evaluation that I ask our members to complete following each meeting, so we get some perception on how did the presenter do, how are they feeling about their contributions in the meeting, does it feel meaningful to them? And I'm curious, I sort of raise this just to invite others' thoughts, if any of you, if not during this discussion, maybe on a break, have thoughts or ideas to share about how you collect feedback with your stakeholder advisors. I'd be interested to hear about that.
We are not only collected the feedback for the CAP, but we collected feedback for the researcher too. We always call back the researcher and ask them how was it, if they answer all the questions that they have. So that helping, and then we go back to the community advice panel and say, well, this is the feedback for the researcher. So they feel very open and happy, and because they feel the work that they are doing or the feedback they are doing is very valuable for the researchers.
I'll just mention that our approach is, I think, a little different from the other two, because each project each research problem that comes to our team convenes a different board of stakeholders that meet the study inclusion criteria, and we define stakeholders very broadly to include not just patients and caregivers, but also healthcare administrators and providers, and wherever the challenging aspect is as part of the research and at any phase of the research project. We try and do it longitudinally, but sometimes the investigators just have a little bit of funds for some pilot or to get over their next hurdle. But the challenge with that is, of course, the timeliness. And so what I heard from you all, which I think is the tough balance to make, is a standing committee that offers that, much quicker turnaround time. And, a lot of times we have the challenges of, engaging different groups, and if it's a rare condition, pulling folks together virtually or in other ways that is sometimes harder to build that trust and rapport, which happens truly over time, but we don't always have that. We don't always have that luxury. We also we do brief surveys of the participants on our patient engagement panels, as well as of the research folks both before and after the services. We are specifically trying to see if their views of patient engagement change, like how they even describe that changes, and in some cases they have, and in others they didn't. But I think the proof is in the pudding from the investigator stakeholder standpoint in terms of our repeat customers, in that the folks that they sort of, essentially get a taste of the Kool-Aid and then they chug it down, right? So, and then they don't need us anymore because they're like, really doing their own thing. So, so that's been one of the most rewarding things for us.
Perfect. So we want to thank our panelists.
Hi, I'm Robin Cruz. I'm a researcher at the University of Missouri, and I've been the core director of our PCOR Center for the past 5 years.
And I'm Jeff Wardway, and I'm a member of the Patient Advisory Board at MU, and I've been a patient co-investigator for the project that we're about to describe to you.
So one of the 3 major projects in our, all right, is that not working? Okay. One of the 3 major projects in our R24 was a cluster randomized trial that took place in 18 primary care offices in the American Academy of Family Physicians National Research Network, which is just too long to keep saying. So this is a practice-based research network of primary care practices that have indicated a willingness to participate in a research study, and they can either agree to participate or not participate in any project that is presented to them.
The participants in this project were patients with chronic non-terminal pain, ages 18 to 75. Half of the practices were assigned a guideline for treating chronic pain, and half received the guideline plus a photo elicitation activity and online support through a private Facebook group. Our outcomes included a 3-question pain scale and measures of patient function, self-efficacy, and pain acceptance. We also collected qualitative data through Facebook posts and through interviews with some patients and lead physicians at each one of the practices. So about photo elicitation, it's a word a lot of people don't know. Photo elicitation is using photographs to illustrate a patient's lived experience. In this case, that lived experience is with chronic pain. So to create a basis of this creates a basis of conversation between your patient and provider in order to facilitate a greater understanding of the patient's lived experience and the patient's condition. A training video showing a sample patient-provider interaction of this methodology was provided to the providers of the study. We also did a few phone calls to our study team. Providers would call and we would iron out wrinkles, provide additional training. Patients and providers used a tablet to fill out questionnaires at 4 points during the study, baseline, 3, 6, and 12 months. And as a patient who lives with pain, I was asked to be a part of this process. I attended weekly meetings of the study team. I provided input on everything from correspondence to processes, the data collection and analysis, and was even involved in the naming of this project. It's been a fascinating and rewarding experience. I was also a member of the Facebook group and acted as co-moderator along with another member of the study team. We found that it was very, very helpful to have someone with the lived experience be a part of this, this group page. So inside the group, along with just supporting one another on our journeys through living with pain, we also assisted in training the patients on this photo elicitation process. So some of our group members actually took pictures of their own. As you can see here, this is a heavy bag, and I'm going to give you 2 examples of what was done inside the Facebook page, and both of those examples were my examples that I shared with the group. So the heavy bag hanging alone unused is a reminder of what my life used to be like when I was a full-on martial artist, something I no longer get to do. So this would be, again, the starting point and basis of a conversation with my physician. Other people, instead of taking their own pictures, scan the internet to find pictures. As an example of this, this was a picture that I used to express How I deal with the onset of acute instances of pain, I view it as something that I just have to surf. Sometimes the wave is bigger than others. Sometimes they're monster waves, sometimes they're small waves. So when I envision my pain that way, my mindset becomes something that I can actually handle that onset and handle that experience.
So we are just now completing the 12-month data collection on the last project. So far, unfortunately, we haven't found any statistically significant differences on our 3-item pain measure. But we still have a fair bit of analysis to do. We're kind of wondering just a while ago if we asked the right question. So maybe not. So qualitatively, physicians liked the guideline that we provided, and most physicians had positive feedback about the photoelicitation and the relationship building with their patients. It gave them the opportunity to talk about the pain in a different way than the 0 to 10 pain scale that we all hate. Many patients also reported positive experiences, but it didn't alter their perceptions of patient-centered care. And unfortunately, only half of the intervention group enrolled in the Facebook group, which diluted the intervention quite a bit.
So despite this lack of statistical significance to date, we still firmly believe, that improving relationships between patients and providers helps, and that focusing on function and not pain intensity is the way to go, and that when we do that, we're headed in the right direction. We also think that using these practice-based research networks can provide a real-world setting where we can try new approaches. We're really, really happy with the outcomes of that.
So, I guess we're going to wait for questions.
We have to swap out the presentation because we had it out of order. So why don't we take one question for Missouri while Diamond swaps out? We'll make the exception, but we'll only take one. And then once we have the other presentation loaded, we'll go to that, and then we'll do group questions as we have for the other panels. So I'm going to take advantage of asking the question unless somebody raises their hand really quickly. Because I did want to know about this. So you didn't get statistical significance, and oftentimes at the end of research, there's lessons learned about what we wish we had asked. So what are the outcomes you wish you had asked where you think you might have found a difference if we had really been even more informed by patients about kind of how this could change care or delivery of care?
Well, I mean, what we're finding qualitatively is that so many times we have the physicians say, wow, I really, really didn't understand until now. I really just didn't get it, right? One of the things we had to do when we first started this study was it was originally entitled Living with Chronic Pain, and we retitled it to just Living with Pain because the word chronic is a separating word. That's a physician's word. I don't live in chronic pain, I live in pain. It just happens to happen all the time. And so when you understand that, as a physician, it allows you to understand my condition better, so it allows you to talk to me in a different way so that we can then move forward with what it is that I want for my care. So what do I wish we had asked? I wish we had found a way to ask, do you understand this better? Do you have a better understanding of the lived condition that your patients are experiencing? And how is that impacting what it is that you do?
We're going to tag team today. So I'm Monique Papadis. I'm an assistant professor at the University of Texas Medical Branch in Galveston. I'm also part of our R24 team, representing on behalf of Jim Goodwin, who could not be here today. We have at the University of Texas Medical Branch PCOR grant, we have 3 projects, but we're going to focus on 2 of those projects today.
Good afternoon. My name is John Cooks, and I am the chair for the Galveston Island Community Research Advisory Committee. So we kind of changed things up on you where we've had the patient advisors and the university. So we're working partner university today.
Okay.
So what we did, for one of the projects that I'll be discussing is related to looking at stroke care, so rehabilitation care, and the differences between those older adults who go to inpatient rehab facilities and patients that go to skilled nursing facilities, and comparing kind of the outcomes differences between them. And so it was a mixed method study where we analyzed the Medicare claims data, and then we also qualitatively engage both patients, former patients, caregivers, and also clinicians. And so we specifically engaged patients and caregivers on trying to understand, their experiences post-stroke, and then, how were they involved in the whole decision-making process from deciding what post-acute kind of care facility that they go to or not, and then, their long-term outcomes and what things that they've faced since returning home to the community after receiving such care.
And with the particular study that we were working on in the bioethical dialogue, I served as the taskmaster and facilitator for a group of about 13 people in the community of various backgrounds around having discussions looking at patient-centered outcomes research as well as comparative effectiveness research on various issues. Each week for about 7 weeks, each participant had homework to come in prepared around articles that were given and what to look for, and then at the last minute I'd become real ugly and changing on them, so we have a real different spin to put it in a different perspective. So that was what we did.
And then how did we do this? So as I mentioned, we engaged them by conducting one-on-one semi-structured interviews in the homes with former patients and caregivers. And we also initially when we started the study, it was individuals who were older adults, 65 and older. Well, as many may know that stroke is now occurring quite often in the younger cohort. So we had to change the criteria to be more inclusive of those individuals and get their voices. So we interviewed, we recruited from stroke support groups, we recruited for individuals that were still living in skilled nursing facilities, and then also retirement living communities.
And as you see, the highlighted word is dialogue. Ours was the conversation around the particular pieces that we presented, whether it was a protocol that was already established or something that was looking at what was the particular participant's lived experience with that. Everybody, we did not initially recruit that you had to be a caregiver. As it turned out, at some point, everyone had been a caregiver at some point in their life, whether it be for family, friends, that kind of thing, and had engaged the healthcare system. So they walked in with a lot of experiences and preformed notions around certain things. And we just want to see how that worked out against the various protocols, et cetera, that we examined, pardon me.
All right, so what did we find? So we found we have tons of data. So just a snippet, really what we learned from, former patients and also the caregivers is that many of the post-stroke kind of consequences occur months, years following their return to the home. And many of them felt that those kind of conditions and how to manage those issues were not fully addressed. And then also the fact that the majority of them felt that they were not really given that option of deciding what kind of care that they received. And so those that went to a skilled nursing facility, they had no clue about an inpatient rehab facility, and why were they not considered to go to an inpatient rehab facility that may be provide more intensive rehabilitation. And similar, those that did go to inpatient rehab, why weren't they, what's the difference? Why is there a difference between these two types of facilities? And many of them felt that they weren't a part of the whole goal setting process, and also in deciding what happens to them once they return home. And then those that did not receive care, the big question was, why do others receive care and I did not?
With ours, as you see, the first bullet is no new news. We knew that, but the importance of that was for the community to get that out as their truth because of what it is that they had encountered and what it just works out to be. Because regardless to what you say, oh, well, the things that come, the truth is the truth. And at that point, I think our cohort from Denver said, be real. And so that was very real, but in that context of that, with the second one, that you should still have that availability of treatments, regardless of whether you have a golden parachute kind of high insurance, or whether you have no insurance. The options and the treatments, the options for treatment need to be there, fully allowing the patient to become engaged and have a true say in that. And then, okay, with the comparative effectiveness research, that because money just spins the wheel and keeps things going, in certain aspects, we're looking to preserve it where we can, and others we just spin, where it comes to the different kinds of help. But even though the research may show that this is that may not be cookie cutter for the patients and what it is that they've lived.
So what does this mean? So, overall for both studies and all the studies, this is part of our patient-centered outcomes research project, is that, there's a need to monitor patients long-term, not just, at that point and then they're gone and then they're no longer engaged into the system, no longer monitored, connecting them to the resources in their community to help them be able to manage these kind of chronic symptoms and consequences that happens after stroke.
I guess what it really means a lot in terms of the system, as I've said in other conferences, and I think it's so true, one of our fellow presenters said, we're preaching to the choir. We have the ingredients for the cake. We know what they are. Everyone sitting in this room basically knows when relative to patient care, it works best, not only the patient care, but the research, that you involve the participant, the patient, whether you want to use them interchangeably or whatever you decide to use that's acceptable to them. So we've got to move past the ingredients, put them together, make the cake, and then share the cake, not only with the patients and the participants, but also with the providers coming up. Because the younger cohorts, do they understand that we need to be engaging that patient beyond walking in, hello, I'm so-and-so, sitting at the computer, putting it in, and okay, never touching the patient. And we know that to be true, whether we want to admit it or not. And so, and for those that have been in that from the old school, that was the way that it's done, we need a refashioning of that. However you get them together, and let's rethink it. And let's redo it and become more patient-centered, and not just that I have 15 minutes with this patient and I've got to move on to the next one because I've got to make sure that I turn over certain amounts of money. So again, I'm going to get off my high horse and step back and give it back to Monique. So she's going to make it nice in the end. Okay.
So just, how we took everything and kind of move it forward, we really listened to the voices of the patients and the caregivers and also the clinicians, because we interviewed clinicians as well. And so there was a big need on, okay, I need help with what do I do, 5 months? What do I do a year from now, 2 years from now? So we've, engaged with our former patients and our caregivers to develop a self-management program. And so we're right now interviewing and engaging the community on, how to put that together for our specific healthcare system. And then we're also working with the physicians to develop something earlier on to help with that decision-making process on deciding where to go after acute care, hospital care, to decide on what type of rehab facility may be most appropriate for you and your family.
One of the things that did come up, they were asking, well, where do we find these things? We come up with the wonderful information. Did somebody put that in the journal for me to find out that when I turn 65, these are the things I need to be considering? So just those kinds of things around not only the patient care, engaging the health system. Where do we find it? We have this wonderful wealth of information, but in general, where's just that lay piece of paper that tells me this is what I need to do? Walk in the doctor's office with a list of questions, and if I don't understand it, or for whatever reason want to shy away from that, take somebody with you that you trust. Where those kinds of basic things we think, well, yeah, they should know that, but no, let's not make any assumptions that we don't validate. Put it there, lead them to the water. That's all I got to say.
Thank you.
Thank you for your wonderful presentation. In reference to the concerns in the field of bioethics from the individuals that you questioned, one of them was choice of available treatment. Could you please expand on pain medications, especially in light of our concerns regarding addiction in Baltimore and the rest of the country? Thank you.
Okay, well, what they talked about, medications, period. Not shying away as patients for the work that needs to be done on our end. Because sometimes they would say, patients will walk in expecting the doctor to have all of the answers, and they've maybe not even asked the question. But before you're going in thinking about, looking at the particular situation, investigate what you need to investigate, talk about the kinds of things, the side effects, everything that goes along with that medicine to see which one actually works, which one does not work, really in being an active partner in talking about the medication that's being prescribed, what does it do, looking at the side effects, knowing their own history and their makeup relative to how they may respond to certain things in that. So that was a big part of just medication, period, not only pain medications. Look at all of the medicines, looking at and monitoring how you react to it, so when you go back, if it needs to change, that kind of thing. So it was really being actively involved in knowing what you would either being presented with and or taking.
One of the big things we found in the Facebook support group was that a number of patients were faced with the fact that their doctors were told that they could no longer prescribe opiates, and people had been on opiates for a long time and were scared to death to come off of them because it was the one thing that had worked for them for a long time. And so they were not in a state of physical addiction, but in a state of fear because they didn't know what would come next. And so what we found was in that Facebook group that there were people who had been on opiates that came off of them and went on to other medications, so we're able to help guide your thought process and your fear so that it made it an easier transition for people who were trying to remove themselves from that opioid taking status. But like you said, you really have to understand, as a human being, you have to understand how you respond to medication. And so, like, I can take certain things that work and I can take certain things that don't, and I need to be able to have that conversation with my physician in order to make an effective plan to move forward. And so, it's just, I don't know. There's a whole wealth of information out there right now and a whole bunch of studies being done on whether or not analgesics and opioids, which one works better long-term, and whether or not opioids are even a good long-term solution to pain when they weren't designed to be that. And so how do we move away from that? I think a lot of it is you got to get past fear, and it's a lot of education. A lot of education that has to happen. Right now the fear is addiction, but the people who are taking that medication are not afraid of being addicted to the medication. They're afraid of being in pain when they come off of that medication.
Yes. On the recruitment issue, did you guys tap into the food pantries and the churches to try to recruit anybody at all?
Yeah, so for this specific project, we did, we focus on those sites, but for our other projects, yes, we recruited within the churches, we recruited, my main role was part of our mammography screening study with older women, and for that one, it was, that boosted recruitment. Women were there, in the Houston area, it's once every month. They go there that first Saturday of the month, and so that was like gold for us with being able to engage the community and get women involved in our study. So yes, the churches, food pantry, community centers, we recruited everywhere for all of our studies, yes.
And I have another question.
Yes.
Before the patient actually leave the hospital, do you talk to the families to find out what the needs are at home? Not when they go to the facility, but what are they going to need when they get home? Do you gather that information right then and there?
So that we didn't, but that specific process is done at the hospital level by many of our case managers and social workers. So that's how kind of decisions are made, is used in recommendations whether or not someone has support or not. That's another key component, kind of distinguishing or what we found between those that go to an inpatient rehab facility versus a skilled nursing facility. So yes, that's we do have someone from that beginning, and so based off of our results and in connection with the physicians, they want to do more than just have the case managers and social workers. They want to have an entire process beyond giving a handout, beyond just presenting these kind of two facilities that may be close by your home, and not really going into greater detail about the long-term outcomes based off of these different type of settings. And so that's what our plan is to do, have it with the self-management, how to handle this condition once you're home for the long term, but also as soon as after the acute stroke care, how to be a part of that process on deciding where's my next step for improving my care, improving my function after stroke. Thank you.
We have one last question.
My question's for the Missouri group. I am wondering if, it sounds like such a great intervention, but it also represents that people want their individual stories to be heard. And perhaps there could be like a sub-analysis that would extract or like basically also look separately at people from like collectivist cultural backgrounds. So people who might be foreign-born immigrants and they wouldn't necessarily want their doctor to know their individual experience. They just want to be told what to do. Because we started to wonder if that's important for our goal setting program too, that some people do want to be told what to do from an expert and not have it be like left to them to decide. So just a potential option to consider so you don't just end up with null findings when some things could be really important. I'm curious what your thoughts are on that. Thank you.
It's nice when you have an expert who can say this is what you have to do and this is going to make a difference. Focusing on function rather than eradication of pain is a huge deal. One of the reasons people like to take big medicine is because it makes the pain disappear. When we focus on what it is that you want to do and what your function is, and then you start to get to an acceptance and understanding that the pain's always going to be there, but it doesn't have to limit you, or that if it limits you, it doesn't have to limit you completely. So if that's the message that you're getting from your expert, that's a different message than here, take a pill, you'll go feel better, right? But the stories, we found that when we ran this past our patient advisory board, we have a fairly diverse group there. And what we found there was that people tend to want to tell their stories, but you have to find the right environment in which that can happen. And so if you walk in and you have a huge mental idea that you and your doctor are on completely different levels and that they're this expert and they should know everything, that's great. But when they open up a door that says, here, let me listen to you just for a minute to understand what's going on a little bit better, it changes that entire dynamic, and you become co-collaborators rather than just, you know, information provider and information recipient. And overall, the quality of care improves that way. So I think that the message is that, yes, there are cultural differences, and yes, there are places where that's not necessarily what people expect, but I think that there's also an education process that can take place that can make them more comfortable, you know, stepping into that role.
We want to thank our last session panelists.
Thank you, and I'll add my thanks and offer them to Daniel and the rest of the planning committee, to AHRQ, Jean, and others, not only for supporting this conference, but the underlying work that's been reported. So I thought I'd take advantage of something that my kids, who are all in their 20s, often remind me, and that is that I've been around a while. I've been involved in the field for quite some time. Not quite long enough for them to legitimately ask me what it was like to only have black and white TV, but the point is valid. And basically step back a bit, several steps to think about where this activity and these ideas fit into the broader, what we might call the arc of history in terms of you know, the healthcare system. Move the mic up, is that better? Possibly standing closer to it would help as well. So, you know, if we compare and contrast where we are now with what we all understand, most of us only understand medicine was like in the 1950s. You know, solo physicians for the most part who did provide routine care, preventive care, but for the most part you went to the doctor or the hospital when you were sick. So all of the trends that have occurred since then and all of the changes, including the fact that we now focus on health overall and quality of life, prevention, chronic disease. We recognize that care is a continuous process, that the relatively small amounts of time that we as patients and consumers spend with our physicians leaves them with relatively little impact on health, so that we worry now about you know, family and caregiver support and patient self-management. Relatively recently, thankfully, we're now beginning to worry a lot more about social determinants and social needs. CMS is now recognizing this with new flexibility and new encouragement. Systems like ours, Kaiser Permanente, are recognizing that oftentimes paying for transportation or paying for food or supporting housing is actually a better buy in economic terms, but ultimately a better way of providing what they would like to provide, which is higher quality patient care and improving quality of life. We're not yet at the level of integration and collaboration that we'd like to be, but the point is that all of these trends, I think, are useful to think about because it does allow us to understand the trends, where we need to be, and to understand some of the changes that have been underway. Now, recognizing the value and the role of patients in health and quality of life, of course, is one key piece this conference is focused on. And that includes, we often like to think about the three different forms of patient engagement. There's patient engagement in their own care, in the care of their families and their peers. VA has done a lot in terms of peer support, recognizing that oftentimes it's veterans' colleagues and peers rather than physicians and nurses who can have the greatest impact. So that's one critical role for us as consumers and peers, family members, caregivers. Recognizing the important role that patients and consumers have to play in health system management, understanding how to design a healthcare system, how to design and manage and improve programs, services, and so on, again, is one of the key roles of the patient engagement or member engagement councils that we've been talking about. And then, of course, patient engagement and research, the idea that research should be designed and conducted in a way that supports the needs and the preferences and the desires of patients and consumers. The idea of a learning health system is a separate but related trend, but again, important to step back a bit and understand what it's all about. The idea that, unlike our misconceptions in the 1950s, that physicians were all fully trained, autonomous professionals who had all the knowledge they needed and the skill and the expertise to deliver high quality care, They had all of that in their minds. That was never the case, and it certainly isn't the case now when the science and the art of medicine are so complicated that it's impossible for individual professionals to, no matter how many years of medical school and training and mentorship, to internalize all of that information. So we have the idea that healthcare systems are now designed and should be operated as formally structured systems with different parts and departments and some sort of explicit blueprint and division of labor. We're not quite at the point and shouldn't be at the point that a Ford Motor Company, for example, is, where everything is fully laid out in the assembly line in the blueprint for care, or in their case for production. There's still a great deal of judgment and autonomy that's needed. But the idea that we provide explicitly guided, evidence-based, protocolized care within a system is now widely understood. The learning health system builds on that to note that whatever the blueprint may be and the set of policies and procedures and standard operating practices, those need to be continually studied and updated and refined. So again, part of this sort of long arc, the evolution of the healthcare system from where we were in the 50s to where we are now and where we need to be, and understanding that, I think, is important in understanding what role patients can and should play in supporting that vision. In an ideal world, the new practices and the new guidance that we've all been talking about would have evolved from some sort of explicit formal process that begins with some needs assessment to identify the needs and leads to the development of innovative ideas. Oftentimes we solve the problem and innovate in parallel or often before we actually fully diagnose the problem. But it is important for us to periodically step back and try to think about why are we designing, conducting these innovations? What are the gaps? What are the problems? What is the overall vision? And one hope that I have for this meeting and others, in the other groups that are involved in this activity, is there would be this stepping back reassessment process of trying to lay out formally the overall vision. Where is it that we're headed? What would we like to see 2, 5, 10 years down the road? What are the key gaps and problems that we currently confront? What are the challenges in getting from here to there? What are the specific kinds of innovations and arrangements that have been developed and proposed? And we can think about laying those out in sort of a protocol article for those who are accustomed to that concept in research, where you actually describe the intervention, describe your blueprint, describe your vision. But also we're now far enough into this evolution in this process to have the ability to talk about what we've learned. So when we think about designing and managing an organization, you begin with your vision and your mission. You then lay out the organization design and your staffing plans and your standard operating procedures. Then you run the thing, and you don't run it and sort of step back and hope for the best, but instead continually monitor and revise. And taking the time to assess where we are, gather up, collate all of the experience, all of the insights, determine whether we're on the right track, and provide both some detailed guidance in summarizing everything that we've learned in all of the blueprints and designs and protocols, but also providing guidance in how they might be refined. I think would be doing a significant service to the field. Again, the idea of preaching to the choir, and most of us who are researchers spend a lot of time interacting with colleagues for whom these are relatively well-known ideas, but that's, of course, not at all the case for the vast majority of the healthcare system. The good news is that increasing numbers or proportions of our colleagues who are in smaller systems and smaller communities have begun to hear about these topics and issues and have begun to express interest. An earlier R13 funded conference that we ran at Kaiser focused on embedded research programs in learning healthcare systems, featured primarily the Department of Veterans Affairs research programs, the Kaisers, the Geisingers, the other large systems, the university health systems. But we also had fair representation, and now we're getting increasing expressions of interest from the smaller FQHCs and county health systems, the smaller ACOs, and even individual medical groups in hospitals. So the idea is that patient engagement, member engagement, learning health systems, internal research. All of these are ideas that, of course, are best illustrated through the large systems, but there's a lot of interest among our smaller counterparts. And the point is, there's also a lot of need on the part of those groups for our guidance and the benefits of what we've done. So the hope is that AHRQ, patients, other groups that have the knowledge, the expertise, the resources, the ability to advocate and convince would help to achieve the compilation of this kind of information to allow us to share our insights, to learn from each other, and to continue to push us along this arc towards the healthcare system that we all would like to see, and that is one that focuses on health and outcomes, does so in a way that respects and values and prioritizes patient needs and considerations, that has very active central roles for patients as full partners, and does so in a way that allows us to continually learn and refine and improve rather than rest on our laurels and assume that everything is working out just fine. So again, my thanks to Daniel and the others, and I think some encouragement and best wishes for all of us to continue to push these ideas. Thank you.
And we want to give a special thank you to all the presenters that have come from all 7 institutions from the R24 original grant, our community advisors, patient advisors, and also our university learning healthcare systems representatives.